Morning, everyone. Welcome to Chair's Grand Rounds. Just going to let people have a 30 seconds or so to join because it takes a bit of a while for Zoom to get everybody in, and then we'll do introductions and get going. Morning, everyone. Just going to give a minute for 30 seconds for people to join. We've got a few more people still joining. All right, we'll get started. Good morning, everyone. Welcome to Chair's Grand Rounds, the second or third of the sort of the 2.5 of the 2021-2022 academic year. I'm Mark Crowther, Chair of the Department of Medicine. We have a special guest speaker today from the small feeder school just to the east of McMaster that some of you may have heard of. I'm going to turn over chairing the rounds to three of my colleagues who are responsible for at least part of our quality program within the Department of Medicine, and we're very excited to ask our guest speaker to present today. So without further ado, I will shut myself off and let them take things from here. Thank you very much.
Thanks, Mark. Okay, so I'm going to introduce our speaker for today. So Dr. Kaveh Shojania is Professor and Vice Chair of Quality and Innovation in the Department of Medicine at the University of Toronto. His research is focused on identifying effective strategies for improving healthcare quality. He attended medical school in Winnipeg, then completed residency in internal medicine at Harvard's Brigham and Women's Hospital in Boston. After a fellowship at the University of California, San Francisco, he stayed on faculty there for several years before returning to Canada. Dr. Shojania held a Canada Research Chair in Patient Safety and Quality Improvement from 2004 to 2013. He's published over 175 papers, including papers in the New England Journal of Medicine, JAMA, and The Lancet. Google Scholar lists over 20,000 citations to his work. In addition to his own research, Dr. Shojania helped shape research publication and healthcare quality through his work as editor-in-chief at BMJ Quality and Safety. During his tenure, the journal's impact factor rose from under 2 to over 7, so that it's now the second highest impact among the 90+ journals in its category, including not just healthcare quality and safety, but also all of health services research, clinical informatics, health policy, and medical education. More recently, Dr. Shojania has become interested in ways of achieving improvements in actual health, instead of just improving health care, by collaborating with groups addressing the social determinants of health, as well as obvious threats to health and healthcare, such as the climate crisis and systemic racism. On a personal note, I was very fortunate to be a student of Kaveh's in the Toronto Masters QUIPS program. And I distinctly recall the first time I sat in the classroom with him, so eager to soak up everything I could about how I was going to help change healthcare. In that first lecture, I listened to Kaveh speak about the importance of a good theory to guide your quality improvement interventions. What followed after that lecture were a number of subsequent lectures throughout the year that each deeply impacted me and framed my outlook on the work we do. I'm always captivated by his realism and his connection to what's really important, and I'm confident today's talk will be no different. So Kaveh, please take it away.
Oh my gosh, thank you, Seychelle, for such a kind introduction. That was really very touching. Thank you so much. And thank you, everybody, in advance for your attention. Let me just, share screen. I'm always a little bit of a fumbler here. Here we go. Slideshow, swap settings. There we go. Okay. So yes, thank you again for that kind introduction, Seychelle. And thank you in advance, everyone, again, for your attention. This is a talk that I've been working on and evolving over the past 6 months or so. It's still a work in progress, so I'll definitely welcome feedback on the ideas I'll be presenting. Without further ado, no actual or potential conflicts of interest to disclose. So look, as we all know, we face a number of massive crises with devastating effects on society in general, and each of which exert direct and indirect adverse effects on population health and healthcare systems. These crises include the current ongoing COVID pandemic, the near certainty of future such pandemics, the existential threats of the climate crisis and collapsing ecosystems, ongoing structural violence against racialized groups, worsening income inequality, which is really approaching the levels seen under feudalism, and the opioid epidemic, which, as we all know, in parts of Canada, the United States, actually lowered life expectancy even before COVID did so. Because of these crises, many have pointed out the importance of not returning to pre-COVID normal. And actually, a few weeks ago, some of you may have seen over 200 journals published simultaneously this call for emergency action to address the climate crisis, a call to limit global temperature increases, restore biodiversity, and thus protect the health of everyone on the planet. And the editors called on governments to make fundamental changes to how we organize society, how our economies are organized, how we do transportation, production and distribution of food, markets for financial investments. They mentioned the health systems in one phrase and much more. So again, this is a crucially needed call and a much welcome call for action. But why no fundamental changes to how we organize healthcare or what we prioritize for biomedical research? It's hard to imagine how the main types of basic and translational research we have been conducting or our approaches to improving healthcare will deliver worthwhile benefits in the face of the scale of the adverse health impacts of these massive crises. Why has there been so little questioning of research priorities? Probably because the mainstream view holds that we are very good at making important advances in research. We're just not that good at translating those advances into practice in a consistent enough and timely enough fashion. And this simple diagram makes clear why many people, especially in Canada, refer to knowledge translation and implementation science rather than quality improvement, because under this model, quality improvement consists entirely of taking the evidence established first in basic and translational research and then clinical research, and then just moving it into practice. I put that citation at the bottom just to show that actually until relatively recently, I held that view myself. But I have come to question this view. I think it faces two fundamental challenges shown here on the slide. The first is that most improvement interventions, when evaluated rigorously, either do not work or achieve small gains. Larger gains tend to occur only for narrow targets. The second challenge is even more fundamental, and that is that most clinical interventions also turn out not to work or to confer small benefits, so are not that worth translating into practice anyway. This was actually a terrific systematic review from Mac over 25 years ago. I, for some reason, often think of it, maybe because of the title, No Magic Bullets. And this, at the time, in 1995, these investigators reviewed over 100 interventions to improve professional practice and concluded that we have, quote, no magic bullets. Most interventions achieved small to modest improvements in recommended practice. Now, the bullet points on this slide are to more recent meta-analyses. And what all of these have in common is, first of all, they're commonly used interventions to change practice, computerized decision support systems, audit and feedback, or what many people call performance report cards, and educational outreach, which is sometimes called academic detailing. Now, each of these results shows the absolute increase in patients receiving recommended care or not receiving inappropriate care. And you can see that they all achieve about a 5% absolute improvement, which I would argue is far too marginal. Why is 5% so marginal or so disappointing? Well, I'll use this example. The most recent example, which I was a senior author on, came out just last year in the BMJ. And we reviewed 122 randomized controlled trials, including 1 million patients and over 10,000 clinicians. And the median in the control group of people already receiving whatever the decision support was recommending was 39%. The meta-analytic result was an absolute increase of 5.8%, call it 6%. So that means with computerized decision support, 45% of patients receive desired care, but over a half, 55%, still do not. Now, sometimes we achieve more robust successes, like this modification to the emergency department order set that basically removed urine culture and nudged clinicians to order urinalysis with reflex microscopy instead. And as you'll see, this actually had a substantial, almost 50% reduction in the urine culture rate. That's definitely not a marginal effect. It's nice to achieve that sort of effect, but for every one of these nudge type interventions that works, there's many that don't work. And also, this is a very narrow target. We're going to get where we need to be with multiple projects like this addressing such narrow targets. This problem of narrow targets comes up a lot and applies to virtually all of the noteworthy successes in quality improvement, just as I would argue in the rest of biomedicine. This very well-designed and executed intervention in the New England Journal a few years ago targeted high-risk prescriptions for antiplatelet agents and NSAIDs. And it was a thoughtful, multifaceted intervention, including educational outreach and also some financial incentives to review cases. And you can see in the middle panel that there is a robust 40% relative reduction. And you can see in the post-intervention surveillance period that this effect was more or less sustained, which is terrific. But as indicated in the bottom of the slide, this intervention affects only 3.7% of patients even taking these high-risk medications. We can't possibly undertake multiple concurrent projects like this in which we have educational outreach, financial incentives, and whatever we do with the intervention, each of the practices receiving these reports needs to then do quality improvement projects to try to achieve the robust reduction that you see here on the slide. So there's no way we have the bandwidth to go after in a whack-a-mole-like fashion all of these narrow targets. Now, these other examples before that, like for report cards and computerized decision support, were for single interventions applied to multiple targets. What this slide shows is that we have the problem of small improvements, even for common conditions like type 2 diabetes. This was a meta-analysis that I first did and published in JAMA in the early 2000s, and then was senior author on this in the Lancet. And across this meta-analysis of 142 randomized control trials, the improvement interventions reduced hemoglobin A1C by just 0.37%, which homeopathic is maybe too extreme, but as we all know, the target is 7%, but most patients are at 8 or 9%, some even higher. So 0.37% reduction won't really mean much except for people who are already almost at the target anyway. And as you'll see, the other endpoints also had very small effect sizes. Now that meta-analysis was from 2012, but not much has changed then. And some of you may have saw this paper in the New England Journal, I think it was just a couple of months ago, that showed that it actually was a longitudinal study comparing the early 2000s over the more recent 10-year period. But I would say the main headline is just that only about 50% of adults with diabetes achieve target control for hemoglobin A1C, blood pressure, and lipids, and only 20% achieve control for all three of these basic intermediate outcomes. Okay, so that's the brief overview of the basis for the first point. Most improvement interventions, when evaluated rigorously, either do not work at all or achieve small gains, or they involve narrow targets. The second point, though, which I'll turn to now, is that this also applies to most clinical interventions, so that it's not worth translating them into practice anyway. Now, I realize the development of COVID vaccines in less than a year gives the impression that biomedical research routinely produces useful solutions to pressing health problems, and that the only issue lies with delays in translation, like with vaccine hesitancy. Yet when one reflects on the typical results reported in major journals, most rigorous evaluations end up showing that potentially promising therapies don't work at all or have much smaller impacts than we thought. So I would say that the COVID vaccine represents the exception rather than the rule. Here's a study to back up this qualitative impression that we see far more null results than we do positive ones. This study looked at large cardiovascular trials funded by the NHLBI at the NIH, and it compared 2000 before and after 2000, when clinical trial registration became more common. And as you'll see on the slide in the second bullet, that prior to 2000, when you could basically report whatever outcome you wanted, 57% of these trials reported significant benefit of the intervention. But afterwards, when you had to stick to your primary outcome, only 8% of trials were positive. There happened to be a different analysis restricted just to trials published in the New England Journal and JAMA. And even with that extreme selection bias, the positivity rate was still only 25%. So despite massive investments in cardiovascular research, most therapies, once rigorously evaluated, don't pan out, as with, I would argue, most medical research. Even when they do pan out, they have small effects, even cornerstones of clinical therapy like statins. Among patients with established atherosclerotic cardiovascular disease, 33 to 100 patients need to take a statin for 10 years in order to prevent one cardiovascular death, MI, ischemic stroke, or recurrent ischemic event. And just to make clear, this summary comes from UpToDate, not some fringe publication taking pot shots at mainstream medicine. The second point is an intriguing analysis I happened to come across, which used the trial data to model Kaplan-Meier curves. And as you'll see, restricting their analysis to trials with at least 1,000 patients and at least 2 years of follow-up, statins postponed death by just 10 days in primary prevention trials. And even for secondary prevention trials, it was only 17 days. Imagine if instead of a vaccine for COVID, we spent billions of dollars a year on a medication that 33 to 100 patients needed to take for 10 years in order to prevent one COVID-related hospitalization or death. We are so used to seeing therapeutic effects reported in terms of odds ratios and relative risks, often for disease-specific endpoints, that we forget the rarity of medical interventions that materially improve the length and quality of people's lives. I could give other examples, but will instead make the general point that the primacy of randomized controlled trials in medicine itself reflects the small effects of most interventions. We need randomized controlled trials precisely because most things we evaluate don't work that well. They need to ensure balanced distributions of known and unknown possible confounders, and the use of various forms of blinding reflects the reality that all of the following have larger effects than most medical interventions: chance, psychological effects on patients, clinicians, and outcomes assessors, and confounding socioeconomic factors. Some of you may remember this piece from the BMJ Christmas issue almost 20 years ago now. It was a tongue-in-cheek systematic review of parachute use to prevent, quote, gravitational related trauma. The joke here is supposed to be on rigid EBM advocates calling for randomized controlled trials instead of relying on observational studies that show obvious benefits. But the real joke is on the whole of the biomedical enterprise for producing so few parachutes that we keep needing randomized controlled trials to evaluate what we produce instead. So in a nutshell, that's the basis for these two fundamental challenges to this conception of biomedical progress. Most improvement interventions don't work that well, and the above turns out to be true for most clinical interventions. It's not worth translating them into practice anyway. But if this were true, surely we would have noticed some concrete signals in population health. Well, in fact, we have a number of such signals. Here is a particularly arresting one that I stumbled across a couple of years ago. Some of you may remember from your travel days. This is the London tube map, but with the stations showing the average life expectancy for the surrounding neighborhood. If you look at that red line going from west to east along the middle, you'll see that there's stations with very high life expectancies, like 90 and 96 years, and it decreases a little bit to 85 and then down to 79 just 2 stops later. It's hard to think of medical interventions that have a 17-year differential effect on mortality. The only interventions that I can think of with those sorts of effects are public health and living standards, the things that we've watched be eroded over the past 75 years as we pursued an agenda dominated by precision medicine. I think we all know there are massive economic inequalities. We live in a world where individuals have more personal wealth than entire nations, but I don't think everyone appreciates just how massive the impacts on health are produced by these socioeconomic disparities. These photos come from a piece in the New York Times about a year ago, profiling 2 neighborhoods in Chicago that are 8 miles apart and have a 30-year difference in life expectancy. You'll see on the left, this is the more affluent, mostly white neighborhood with a median income of $100,000, median house value of $500,000, and a life expectancy of 90 years. The median income in the poorer, mostly Black neighborhood, you can see, is about a fifth of the one on the left. Same with the house price, and you can see the life expectancy only 60 years, 30 years lower. Now, in Canada, the longevity differences are not quite so egregiously extreme, and we don't have such a nice pictorial depiction as that London tube map, but we have had some studies showing similar results, including the Code Red project in Hamilton some years ago now, a similar one in Sudbury, and one in Winnipeg. And the 18-year difference in life expectancy between the 2 Winnipeg neighborhoods equals the difference between average life expectancy in Canada now versus that last seen in 1940. Now, the residents living in that poorest neighborhood in Winnipeg are predominantly First Nations, the group which probably bears the starkest impacts in terms of place of residence and health. I've shown that here for boil water advisories, which has been in the news lately because of the situation in Iqaluit, but I could have picked mental health or any number of other health conditions. Some of you may know that First Nations have a threefold increased risk of suicide in general and 9-fold higher on reservations. This graphic comes from the Canadian Medical Association, and while one may quibble with the specific percentages assigned to each category, it's hard to argue with the qualitative picture that what we prioritize for biomedical research or even clinical health delivery does not reflect what makes most of us sick. And Don Berwick, who some of you may know is probably one of the most famous people in healthcare quality for decades now, he had a very powerful essay in JAMA last year called The Moral Determinants of Health. And he basically said that we have to, the fundamental question facing us is whether we just want to be a repair shop, if that is all we see ourselves at. Now, some of you may say these are socioeconomic problems, not healthcare problems. Maybe, but healthcare consumes 40% of provincial budgets. If we keep taking all the money and not doing anything about the social determinants of health, how will we achieve any useful improvements in population health? Healthcare as currently organized does not improve basic health outcomes for much of the population, and this will worsen as economic deprivation becomes more widespread following the pandemic and as the impacts of the climate crisis become more frequent and more devastating. And just on a personal note, I'll say this summer, I was visiting my mother in the hospital in Winnipeg during the worst part of the heat dome and the wildfire smoke. And even in the palliative care suite in the teaching hospital, my eyes were stinging from the amount of smoke in the air, even in the hospital. But these are not really research problems. Well, I would say it's actually not at all clear what the most effective or efficient strategies are for improving the social determinants of health. That's why, for instance, as some of you may know, there have been trials of universal basic income, something that was receiving more attention last year in the early parts of the pandemic. What is clear is that the social determinants of health all have greater impacts on health than do individual biology or the medical therapies that consume most of the massive budgets for healthcare delivery and receive almost all of the funds for research. Well, what does this sort of research look like? I mean, obviously, there's lots of examples. There are some researchers who have devoted their careers to this, but it's often way out of the limelight. This was a paper from Canadian researchers in JAMA a few years ago. Some of you may know this. It involved 4 Canadian cities. It was an intervention targeted at homeless people with mental illness. And as you'll see, in each of the 4 cities, there was at least a 30% absolute increase, sometimes as high as 50% in the number of days stably housed. This slide shows an example tackling the leading cause of death amongst racialized men in Chicago, I think maybe the United States in general, where homicide claims more lives than the next 9 leading causes of deaths combined. This was actually a really inspiring example I came across in a recent book called Upstream. And this was an intervention developed by a nonprofit group, which then the University of Chicago's crime lab became involved with, and has now been in 2 randomized controlled trials shown to reduce total arrests, violent crime arrests, and increase graduation rates by substantial amounts. And actually that picture shows in the white shirt, that's President Barack Obama attending one of their meetings. I came across this similar example from Winnipeg, actually, published in the emergency medicine literature. This was a feasibility trial of an intervention to reduce repeat violent injuries and sort of exposure to the criminal justice system. And the trial was just meant to demonstrate feasibility, which they did by randomizing 120 odd patients. But there were also some signals of really important outcomes, like a reduction in violence-related injuries and new interactions with the justice system. And they also achieved these things without any increase in the ED length of stay. Now, it seems daunting to take on this sort of work at all, never mind doing so outside of a research setting and the resources that that can bring. That's why this story a few months ago was so inspiring. It was in the Globe and Mail about Doctors Louisa Marion Belmar and Julie Sampson, who work in Timmins, where they came to realize they had a per capita rate of opioid overdoses that was twice that of Vancouver's and 4 times the provincial average. They noted a number of obvious shortcomings, like that there was no detox beds in the local hospital. I think the nearest one was an hour away. The RAM clinic wouldn't accept patients without a referral. And the police basically continued their usual practices of just arresting addicts and letting them go up through withdrawal and lockup. So they gathered the facts, met strategically with different people, and finally made a very impactful presentation to the city council. And through their efforts and those of others they engaged, the hospital opened up some detox beds. The RAM clinic started seeing drop-in visits, and there was now a new police unit dedicated to providing more support rather than just arresting people and locking them up. So there's obviously lots left to be done. Achieving real impact takes time, a point that I'll return to in a few minutes. But before that, why have we not tackled the social determinants of health or other prevention-oriented goals? Well, first, I think we all know clinical training prioritizes short-term goals of fixing and curing, and academics is the same way. It rewards short-term signs of impact. It's also easy to view prevention as someone else's job, and there's massive commercial interests in the current approach. And also there's the dominant political ideology of neoliberalism whispering in our ear all the time that emphasizes individual actions and accountability over social forces. And this ideology, in my mind, is epitomized by Margaret Thatcher's outrageous statement, as we all know, there is no such thing as society. What might we do about this? Well, we could acknowledge we have a problem, a major mismatch between the dominant causes of poor health and what we prioritize in biomedical research, as well as healthcare delivery. We could also do more policy and advocacy work, leveraging the resources and social capital enjoyed by healthcare. We could also tackle some complex structural issues in our own backyard. I've given just one example here. I'm sure it will be contentious, but we are living through a pandemic that has highlighted the expertise of a subspecialty, infectious diseases, which has never been well paid and is never on any hospital or research institute strategic plan, and also an entire specialty, namely public health, which is even more poorly recognized and remunerated. Are we really going to go back to making the same types of inequitable judgments we have before, that some subspecialties should be rewarded more than others? And finally, we could rethink our research priorities and frameworks for impact. If we value better health for the whole population, we cannot keep directing most of our resources at activities with so little chance of achieving that goal. Here's an example highlighting the need for a more balanced approach. On the left, as noted here in the first bullet, there's 121 agents in clinical trials for the treatment of Alzheimer's disease, 29 in phase 3. The most likely future outcome is a statin equivalent, a medication which 33 to 100 patients with cognitive decline need to take in order for one person to derive worthwhile benefit, or for most people to derive a tiny benefit. Why, especially in the wake of COVID, we continue to predominantly pursue that path and not focus on the obvious structural problems in how we deliver care for the elderly, better models for caring for them in the community, developing and refining new models of long-term care, and optimal staffing levels and payment schemes for healthcare workers in long-term care. Here's a climate-related example. This first bullet point refers to a paper in the New England Journal that came out in the late 2019, just a few months before COVID. Across 652 studies, they were able to show a 0.5% increase in all-cause mortality within just 48 hours of small to modest increases in particulate matter, ambient particulate matter, basically pollution. There was actually a really elegant study in the BMJ just a couple of weeks ago from Canada showing 5-year mortality up to 13 years lower among Canadians who moved from highly polluted to less polluted areas, and actually reverse trend for people who moved in the opposite direction from less polluted to more polluted areas. Some of you may know that last summer during the wildfire season, there were some papers that documented increased ambulance dispatches within 1 hour of exposure to the smoke, and that there were similar results in California, and actually a paper in Australia documented excess mortality similar to the New England Journal paper above. And the WHO has had a campaign for a few years now emphasizing that about 25% of heart attacks and strokes are caused by pollution, and that the global mortality of pollution is now approximates, it's actually slightly higher than that from tobacco. So in that context, do we continue to invest mostly in endless permutations and combinations of inhalers, or do we collaborate with those in other sectors to develop ways to curb sources of pollution and improve air quality, and develop strategies so that the healthcare system can have the resilience to handle the surges in patients that will come during predictable increases in temperature and decreases in air quality? Now, these things will obviously take time, and that can be depressing, which is sometimes why I like to remind myself of this quotation. Some of you may have heard of it attributed to Bill Gates, but it was actually already around in the 1960s. But anyway, Bill Gates deserves credit for bringing it to attention, because people do tend to overestimate what they can accomplish in 1 year, but underestimate what they can achieve in 5 to 10 years. the hope that that quote brings home to me was, I was reminded of it last year when I read this extraordinary book by Stanley Robinson. Some of you may know, if you're a science fiction fan, his work. He won basically every award for his Mars trilogy. But this was not that type of science fiction. It takes place now and over the next 30 years. It opens with horrific depictions of catastrophes, including a heat wave in India that kills 20 million people. But then plausibly and inspiringly, it depicts the ways that people around the world make important changes to how we organize society. The action spans the globe with popular uprisings, eco-terrorism, and even a new type of carbon currency, asymmetrical warfare and student debt crises, and so on and so forth. One terrific aspect of the book is the way it deals with the problems of massive financial inequality and the ideologies of racism and cultural displacement, which have contributed to so many of the massive crises we face, not just the climate crisis. And on that note, that so many of the massive crises we face ultimately have to do with questions of equity and othering, I thought I'd end with this passage from an essay by the novelist and activist Arundhati Roy from last year in the Financial Times. She wrote, "Historically, pandemics have forced humans to break with the past and imagine their world anew. This one is no different. It is a portal, a gateway between one world and the next. We can choose to walk through it, dragging the carcasses of our prejudice and hatred, our avarice, our data banks and dead ideas, our dead rivers and smoky skies behind us, or we can walk through lightly with little baggage, ready to imagine another world and ready to fight for it." And with that, I'll just say thank you for your attention, and I'm happy to answer any questions or discussion that there might be.
Thank you, Kaveh. As always, it's like so thought-provoking, and I appreciate you taking the time with us to float this to the larger group. I especially love that you don't really shy away from any of the controversy, and so I'm hoping that sparks a few questions within the audience. One of the first questions or comments that we got was that this should be mandatory CME for most of our faculty. So there you go, Kaveh. We'll probably be having you back in the near future. Okay, so the first question is, how do we teach people to become more resilient and desire to get better and healthier from a population perspective?
Oh, that's a great point. It's funny, so many, I mean, having been in, this may seem like, what does this guy in quality improvement have to do with any of this stuff? And I'll say that what it has to do with is in patient safety, which is where I started. The whole point was, some of you may remember who've been in practice for at least 20 years, the whole point was that shift from the focus on the individual bad actor to the system problems. And the idea was that there's just not enough incompetent physicians to account for all of our quality problems. It must be that we have a poorly designed system and that anyone in that situation could have made that error. And yet over the past 20 some years, we've made not a single system change, not a useful one anyway. And actually, some of you may know, this is going to sound totally out of left field, if you've been following any of the critical race theory debates in the United States. What critical race theory, which is now illegal to teach in a number of states, it's amazing that that country can even do that. But in any case, it's basically the idea that even though there's civil rights legislation and so on, there's still lots of systemic racism. We haven't made the systemic changes we need. And resilience, that comes up a lot too, is that even when people's heart's in the right place, we often end up sort of defaulting to like individual strategies. And there's only so much yoga you can do, right? There's only so much mindfulness you can do. Like if you don't actually change the structural causes of people's mental health problems, you're not going to fix things for us. And then for our patients, similarly, even some of the upstream work, like, well, you should exercise more, this and that, like, we're just not going to get there without interventions that involve urban planning to have more walkable neighborhoods. And, if you're a relatively poor, obese person with diabetes holding down 2 low-paying jobs, you're just not going to be able to go to the gym. I mean, so we do need to think about, that's why, I don't know what the specific answer is, but I do think we need more cross-sector work looking for obvious structural changes that will affect population health. And then if people want to talk about personal resilience for healthcare workers, I would say the same thing. We need to find that right balance between things we can do to help individuals, but also not lose sight of most of the change has to happen at a system level. I hope that answered the question. or sort of, as good as I'm going to come up with off the top of my head.
I'm going to open the floor for Herzl. I don't know if Herzl, you can ask the question through the.
Yeah, we're not able to unmute him, but I think Mark should be able to unmute Herzl.
Just give me a sec. I will do that. I got to find them in the list here.
He should be at the top just because his hand is raised if you go to the attendee. Awesome.
Allowed to talk. Okay, Herzl, I'm allowing you to talk. You have to unmute yourself.
Yes, thank you. No, thank you, Mark. And that was an excellent and very appropriate presentation, and I think it's very thought-provoking. So thank you for doing that.
Thank you.
And as you've already, intimated, past pandemics have made huge changes. For instance, the Black Plague essentially ended feudalism in Europe.
Yes.
Because workers basically were empowered to go and look for jobs because there weren't enough around. So they didn't have to be serfs anymore. So yeah, I am sure we're going to have all sorts of changes that are occurring in our society. And I think it's going to be hopefully for the good. But I think it's really important to step back a bit and distinguish between two types of things that you're talking about. Number one is prevention in the broadest sense. And prevention has so many different aspects to it. And I think you very beautifully highlighted the relevance of prevention. And most of these are population level interventions. A perfect example is we can tell individuals so much they have to get a vaccine, but when you make a vaccine mandate with a population health approach as opposed to an individual approach, people get their vaccines, even if they said they wouldn't get their vaccine to a large extent. So I think that's super. And the same with living in societies that are healthier versus not. But at the same token, I think we have to not kid ourselves that effect sizes of population interventions on the individual level are very small. You need to do randomized controlled trials, for instance, to show that a population intervention makes a difference. And a classic one is a moving to opportunity study that was done in the United States, which showed that moving from a poor to a richer area reduced the risk of obesity and diabetes, but the effect size was not 50% absolute risk reduction. It was a definite, it was a 40% relative risk reduction, but the absolute size was low. And you could never have done that without a trial. So, and I think the last point, so we still need to do trials, even population health related trials. And the last point is that regardless of what happens in population, individuals are still going to get sick, and our healthcare system needs to treat people who are sick as opposed to populations. And that is what the public is willing to pay for. Unfortunately, the public is not willing to pay for politically population interventions that might improve society if it means that they're not going to get care when they have a heart attack, or they're not going to get the best care when they have a stroke. And the Alzheimer's, for instance, is a great example. If we said we're no longer looking for any therapies to prevent or delay Alzheimer's disease, all that money is going to go into just treating people who have Alzheimer's disease. It'll be very difficult to get the type of political support in order to do that. So I think all I'm saying is that—
No, I get what you're saying. I totally get. First of all, I'm not suggesting we do nothing, and I think you know that. I am just trying to get people's attention. But I will say that we need to think about, are we just going to stand back and sort of review the public as having fixed ideas that we can't do anything about? Like, that is one of our problems too. Like, look at what's happened with the vaccine, right? Like, we have paid so little attention to perceptions in the public. There was actually a nice paper in the New England Journal, a commentary a few months ago on information epidemiology, that if we'd applied the same techniques that we use to monitor the progress of the pandemic to fake news, we could have acted and nipped these things in the bud in a much more timely fashion. So I guess I'm just trying to say we need more attention to that. We need more attention to getting healthcare providers and physicians and others out there shaping the public opinion and showing them that curing cancer is not the only thing that we should be building wings of hospitals for and funding. So anyway, I get that there's still a role for trials. The point that I was making about trials is that we often think of them as this key thing for advancing knowledge, when the reality is mostly it just shows that things don't work. And the reality is also that the reason we need them so badly is because, just as you said, often things have small effects. But it does sound like we're mostly on the same page, and I do take your points that there's obviously more nuance here, but there was no way to sort of get people's attention without sort of picking maybe a slightly more extreme version of what I think the actual state of affairs are.
Well, thanks for doing it. I agree with you. So I appreciate it.
Thank you, Dr. Kirstein.
And it's Mark. I'm just going to make a comment. Don Bodish, who's the director of the Firestone Research Institute here in Hamilton, points out that even before the pandemic, infectious disease research and our Infectious Diseases Research Institute was actually part of our university strategic plan. But that doesn't dispense with the fact that there are gigantic income inequalities, which put certain specialties, including infectious diseases, at the bottom of that list. So we have been focused on this for a while at McMaster, although I don't know that the issue that you raised has actually been addressed any better here than anywhere else.
No, actually, I saw that comment in the chat. I was impressed that infectious diseases was on the strategic plan at MAC. Another reason to like MAC, actually, I've always admired MAC, obviously. Anything else, Sean?
Yeah, so there's a great note by Brittany Dennis, who's talking about the role of social media and maybe this epidemiology of information exchange and how it relates to spreading misinformation and impacting millions of people, maybe even on a kind of a dose response public health intervention type approach. So her question is, I am wondering how you think we can tackle this, or if you've seen any studies or research in the context of QI that allow us to think differently.
No, it's a great question. Thank you very much. Look, again, I don't know the answer, but I do know we need more research on this. And to show, there is actually some research. There was actually a paper in the PNAS, amazingly, a year and a half or so ago, that tested the hypothesis of the echo chamber that we've all heard about for social media, that, these young people, they're never having their ideas challenged and they want safe spaces. And this idea that on Twitter, you only ever encounter people with your own ideas. So what they did was they found a bunch of Democrats and Republicans to agree to be part of this experiment where they would be fed social media sort of from the other side. And actually over, I forget how many months, maybe 6 months or a year. And then they sort of checked how their ideas had changed. And actually for the Republicans, they had actually they doubled down, so to speak. The exposure to the other side actually entrenched them more. For the Democrats, there was a slight trend, but non-significant, towards them maybe changing their views. But the point is that we do need more research on this. Like, there is no simple solution, but I mean, we all know biologically, sort of theory of evolution, that at some point, biological evolution lags behind social evolution. It's easier for a society to protect its citizens than it is to rely on genetic mutations anymore. And so we have these powerful social forces that we've mostly ignored or just complained about when they thwart what we want to do. And I think there's just nothing else for me to say except that should be the focus of most of what we do. It's actually funny, there was actually a French physician 200 years ago, René Viermet, I think his name was. He was a surgeon and sociologist. He actually showed a picture like the London Tube map 200 years ago of the arrondissement in Paris with the mortality in each neighborhood. And he thought that the job of the doctor was to be as much a sort of surgeon to society. And I just think we've totally lost that. And we need to, it's crazy to think that we could use precision medicine to sort of improve the health of our whole society. Of course, it will have some important advances from time to time, but we need to be more balanced. And I think the information and social media and popular opinion and so on is something that we definitely need to pay more attention to. Though I will also say that I know that's not going to be a cakewalk. All that there could easily be a backlash against physicians if we start saying things without being thoughtful about it. This is why I'm saying I think that some of quality improvement and healthcare research in general needs to focus on how to do this sort of work in the social space.
Thanks, Kaveh. I was actually going to ask a question that I think two other attendees have also asked is the question of what do we do as individual physicians in terms of trying to tackle this, because this is such a large area to focus, and certainly, some of the lens and quality improvement could be shifted. But let's say those that are not in quality improvement, or how do we get started on this as individual physicians?
Oh, it's a great question. And I mean, this has been the dilemma all along for anyone who's wanted to work in the space is, are we the right people to do this? So we're not really. I mean, we should be collaborators, but obviously there are people whose all their academic or professional training is working in these spaces. So that we have a choice. We can either hand back all the money and say, guess what? Taxpayers, we guess we haven't really been doing much, even though we always say we're not doing much for you. That's never going to happen. So what we can do though is say, okay, we're going to work with these people more. And again, I'm not suggesting that we just radically stop everything we're doing, but I'm saying that a massive amount of the research enterprise is focused on stuff which has no chance of improving health anytime soon. One example that I think about a lot is sickle cell disease. I mean, I worked in the United States for a number of years, and so I saw a lot of mostly Black patients suffering with pain crises and being stigmatized and treated in racist manners and so on. And I mean, in January, I think it was, the NIH had a piece in the New England Journal, Francis Collins, calling to this wonderful success that, stem cell, or what is it, CRISPR-Cas9 treatment for sickle cell disease. So the amino acid point substitution was discovered in 1949. So in 75 years, we had all these people suffering with no advances. And then now 75 years later, 1 or 2 people have been treated. Like, that is too geologic a timeline to improve people's population health. So I don't know, obviously, I'm not suggesting we're best positioned to do this, but we have been handed all this money historically, and we have a lot of influence. And I think we need to partner with these people. We definitely shouldn't think, though, that we have the expertise to do this, because we definitely need to involve people from the social sciences and social sectors, educational, the criminal justice system, and so on.
This is fascinating. I mean, in my own head, I start thinking about whether or not, like, it seems like we're valuing the hope of a solution versus the ability to move that into a population group and affect change in a less glamorous, more effective way. Like, this almost seems like we're saying, well, let's pull away some of that money and hope. And you can see the people in their minds already thinking, yeah, but what if one of those things does turn out to be the cure for Alzheimer's? Or
I know.
What if that happened?
That's the lottery system that fuels the whole American dream, right? Is that I'll be the 1 in a billion person who actually, like, somehow makes it. I just feel like we can't keep doing that. It's just, there's too much at stake. I mean, I just say the climate crisis for me, I mean, obviously everyone's thinking about it now, but when I was editor of BMJ Quality and Safety, I think it was 2017, we got a submission from some hospital I'd never heard of in the United States. It wasn't a famous academic center, on the quality improvement projects they had done to make up for the shortage of sterile saline, which we didn't have a shortage at the time, but 2017, I mean, we didn't have one in Canada, so I didn't know about this, but Hurricane Maria had devastated a couple of pharmaceutical factories in Puerto Rico. And that's where 50% of the US's sterile saline was. So suddenly there was this big shortage. And now, obviously, with COVID, we've all become used to supply chain disruptions. But this is like a massive, massive topic that has received almost no attention, either operationally. Well, now with COVID, it's getting some operational attention, but definitely not from research. Like, what are we going to do to make sure we have resilient supply chains? Like, that will have a more concrete impact on any of the research we're doing in precision medicine. So I do think we need to change the thinking of ourselves and the public about what constitutes like cutting edge biomedical research.
Thanks, Kaveh. The other question I was going to ask is, I know you do a lot of work in quality improvement curriculum, and as I'm reflecting on this talk and just sort of organizational change in general, one of the points that always comes up is, how do we actually sort of incorporate these as part of our medical education rather than trying to change the perception?
Oh, I'm so glad you asked that.
I've been practicing for years and years, so I didn't know if you had any thoughts on that.
No, it's so funny you say this. So first of all, the fundamental, I mean, this is where you get really sort of philosophical, and some people won't like it maybe or whatever, but there's this guy, Avidus Donabedian, who he was a Lebanese Armenian physician in the 1960s. He moved to the United States and ended up at the University of Michigan after briefly being at Harvard. And he was sort of the original person who talked about measuring quality. And he came up with the triad of what's called structure, process, and outcome, that is still paradigmatic. So the idea that you can't always measure outcomes because it takes too long. So why don't you take proven aspects of care, what we do to patients, the processes of care that have a relationship, and just measure those. That's why all those studies years ago that would look at the rates of giving proven acute MI drugs, the door to balloon time, all that stuff, those are processes of care. And then obviously structures of care are things like staffing ratios and how large the hospital is and so on. Anyway, towards the end of his life, he famously said that the secret to quality is love. You have to love your patient just like you love your God. And yeah, it's a little embarrassing to talk in grand rounds even to say the word love or God. But Don Berwick actually wrote an essay essay on this, on the 50th anniversary of this paper just a few years ago. And what's so fascinating about it is he's basically pointing out that there is no ultimate system solution without the professional ethos of caring for your patient. Like that's Francis Peabody said that, the father of family medicine in the 1920s or 30s, that the secret of patient care is caring for the patient, right? Like that's, so there is no perfect system, right? Unless you have that professional ethos. And actually there was a really powerful essay in Any Jam Catalyst last year by a very prominent researcher who said that actually what COVID has unmasked many of the shortcomings of the healthcare system, but the one thing it has highlighted positively is how much depends on professionalism and the resilience of the individual healthcare worker. So what we have to, his point was, we have to make sure that when we're trying to make system change, we don't inadvertently erode that professionalism, that ethos, that resilience, and so on, which a lot of measurement-focused projects do, like we have to just keep whipping the front lines with more performance metrics and so on. So I do think, even though from a quality improvement perspective, education is the weakest change intervention there is, at the same time, there is a role for instilling that ethos and reminding people in practice even like what we're all about. And I find that, that's what people talk about burnout a lot too. And of course, I agree, there's a lot of burnout, but once you're feeling burnt out, you can never take away enough bad things without adding at least one good thing that makes you feel good about your job and so on. So I do think there is a role for education, instilling and inspiring these principles and so on, even though the quality improvement part of me knows that we really need to make a lot of system changes too. So I guess the two need to go hand in hand.
Okay, maybe I'll put another question to you, which is like a nested series of questions, and hopefully maybe we can extract something from that. So let's move to pragmatism here. Like, I'm an individual clinician. I've totally bought everything you say. What does that change look like for me? How do I realign my clinical agenda, my research agenda, to start thinking more wholesomely about these topics? And then moving backwards a level, what does that look like for a department, like the Department of Medicine, or a structure, or a hospital, or something like that that's looking to take these things more meaningfully?
Thank you for that great question. I don't pretend to have all the answers. And actually, in my role as vice chair, I'm just trying to get together a group of people in our department to try to come up with some brainstorming to come back. We've had a similar reaction here. It's like, many people support the ideas, but aren't sure what to do. And I'm not sure what to do either. I just know that we need to start talking about it and doing it. I guess I would say, like with anything, I mean, many of us have read our essays about the climate crisis about this too, is like, what's the balance of what you do personally or what you talk about with your friends and what you try to do more publicly or at a larger picture? And like for everyone, it's a little bit different. Like it can't all be about wagging our fingers at people and, censuring individuals for driving big cars and so on. Although there is a particularly massive SUV that annoys me every time I see it in the Sunnybrook parking lot. It's one of the cardiac surgeons, damn it, I know it. Anyway, but the point is, I guess as a department, I would say, like, there are a number of, this is why when people talk about systemic racism, they point out like why it's important to recognize that it's systemic and not just individual bad behaviors, is there are a lot of subtle structures that we don't recognize as contributing to the problem. Like for a lot of junior researchers right now, when you're starting out, they have no choice but to keep doing the research that we've done before, because they need quick wins to have early signs of progress. It's only when you get to sort of my age and older that you get to sort of really do research. We have to figure out a way of changing that. Now, obviously, we can't give every new clinician scientist or clinician investigator a carte blanche and say, don't worry, you have 10 years. That can only be done for really prestigious sort of like Canada Research Chair type people. But we could still look at the average person in a department. How could we make it so that they're not disincentivized to do this? At least that, like, pay for performance in quality improvement in many ways is that. It's not necessarily that you're paying people to do good. You're at least trying to remove the disincentive of the fee-for-service system and so on that sort of makes it so hard to do good. At least try to make it less hard. So I think that that's how I would sort of put it. I mean, there's no way I can, off the top of my head, answer all these thoughtful questions, but I guess I would say the first thing is everybody could think about if there is a cause or that somehow relates to their research. Like, it's not the same for everybody. Like, I have a physiatrist colleague that I admire who pointed out to me just how devastated people with prostheses have been during COVID. Like, not only is her research now addressing that, her quality improvement type of work, but, some of the advocacy work she does and so on. And, it actually sort of puts a spring back in your step. I mean, I've actually partnered with with a slightly more senior colleague to me, Stephen Wong, who used to be the head of general medicine at St. Mike's. He was on that trial for homelessness in JAMA that I showed. And I'm meeting once a week with his group that's working with the homeless hotels in Toronto. These are some hotels that the city leased from the hotel owners to put all the people in encampments. And they're trying to come up with a model for managing these people in the hotels and getting them stable housing. So for me, that's given, again, a sort of a spring in my step. I remember when I was younger and I met with Don Redelmeyer, who some of you may know is an eccentric general internal medicine researcher here at Toronto. He was the one who first showed that cell phones cause car crashes in the New England Journal in the 90s, but then also was the one who had that paper in Annals showing that Academy Award winners live longer than their age-matched controls. But anyway, he said the secret to being happy is having always one of the 10 projects you're working on be something that you really enjoy. It's a little bit of a sad commentary, but actually some of the work on resilience and burnout says that if 20% of your work makes you feel good about your job, that's enough. So I guess I would say as an individual, try to think about that, try to think about at least one thing that you're doing that maybe aligns with these deeper, longer term goals. And then I think as divisions and departments, we need to think about, obviously we can't stop radically doing everything, but we need to sort of point the ship gradually in different directions. And just one last thing I'll say is I'm not suggesting that there's no basic or translational research necessary. I'm just saying the targets of that work may need to change. You know, we may need to work more on zoonoses and other sorts of things rather than always more monoclonal antibodies for, you know, chronic diseases and so on. Anyway, a work in progress for sure, but the main point of this is to start the discussion.
Perfect. Mindful that we have exactly
Yes.
3.5 minutes, and we were told by
Yes,
Mark that
we can definitely
anything after
wrap it
9
up.
o'clock is. Yeah, maybe a brief thought about how to find money for these things. We have a question in the chat that talks about some of the difficulties in finding funding for some of these areas and how we might think about that. That's obviously a big structured problem. But I don't know, do you have a quick answer that you might want to?
I do not have a quick answer. I do think it's going to have to be a multifaceted strategy. We need to work more with donors and sort of change their ideas about what impactful thing is. Obviously, we need, I mean, places like MAC and the U of T have some clout at places like CIHR. We need to probably make it so that there is some gradual shift in the types of things that are funded. I don't know if how much of it is going to be carrots and how much of it's going to be sticks, but yes, we need to think about the various ways in which we fund research and clinical care and look for ways of shifting some of the focus. But yes, it's just trying to start the conversation. I wish I had more specific solutions to suggest, but it would be crazy to think that I would have the right ones to suggest. But I do want to thank you all for your time and attention and these many really thoughtful questions, and the response to this talk has been certainly gratefully received by me.
Thanks, Kaveh.
Thank you.
Thank you so much, Kaveh. Thanks everyone for attending.
Thanks everybody for attending. Thanks to the guest speaker. We look forward to seeing you in a month, and that was a really great set of rounds, and I'm sure we'll have a big impact. So we appreciate
Thank you
this morning.
Take care, everybody, and happy Diwali to people who celebrate. Thank you. Bye.
That was weird on my, they must have changed the Zoom, because it used to be that you had automatic co-host functions, and you, but that obviously isn't the case. And it used to be that I could set the anonymous off, but that also wasn't the case. So Zoom continued to evolve.
I think our video and audio was on in the sense that we could openly participate, but I couldn't unmute anyone or
you know, I had to give you, it used to be that when you were joined as a panelist at the start, you automatically had co-host permission. But
yeah,
now you
thanks for doing that.
Yeah, anyway, we'll see you later. Thanks.
Thanks, everyone.